Hi, my name is Richard DeVito. Thank you for joining us today. We're pleased to bring today a webinar titled Stress and Mental Health and Emergency Management and the Affiliated Professions. It's okay to talk about it. Today's moderators are Sonny Patel and Kim Guevara. Our panelists are Dr. Eric Goralnick, Dr. Chris Stout, Dr. Timothy Erickson, Mr. Vincent Davis, Mrs. Carolyn Harshman, and Miss Jill Raycroft. I want to thank you all for joining us today. We're very excited to have you here. This presentation is brought to you by the Journal of Emergency Management. The beginning of last year, we decided that we wanted to try and get a lot of the research that's published in our journal out to a broader dissemination. And we thought that the webinar series would be a great way to do that. So we're pleased to bring, this is our second webinar, and we're pleased to bring that forward. This webinar is funded. The funding for this webinar and training is provided by the National Institutes of Environmental Health and Sciences of the National Institutes of Health under the award number U45 ES019350. And that's provided in cooperation with Nova Southeastern University. I want to thank them for their support and the team down there, Dr. Cohen and his team. I really appreciate that. Special thanks goes to the entire team who worked so hard, multiple meetings over several months to bring this webinar to life. First of all, I'd like to thank Carolyn Harshman and Carol Seawack. Let's go back here. This is on. Carol Seawack for bringing the mental health challenges in emergency management to our attention. I'd like to thank Dr. Tim Erickson and Sonny Patel for submitting one of the first papers to our mental health special issue in emergency management, and for entertaining and championing our vision for a comprehensive mental health webinar and a future survey in this field. I'd also like to thank Kim Guevara and Ali Meyer for their dedicated work in this field and for their valued insights and always going the extra mile to bring this presentation forward. I'd like to also say thanks to Thad Hicks, our special issue editor of our GEM COVID-19 and mental health special issue. Thank you, Thad. And I'd also like to thank our distinguished panelists, Dr. Goralnick, Dr. Stout, Mr. Davis, Ms. Raycroft, and Ms. Harshman. Thank you so much, appreciate it. If you'd like more details on the team, you're welcome to scan this barcode here and we'll take you to a listing of all their bios. This is a disclaimers page. Basically, the opinions of our panelists and moderators are their own. By attending this webinar, you confirm your acceptance to being recorded in voice or image. Please ask concise questions, cite your sources, and limit opinion and criticism. Please send all questions through the Q&A session, Q&A function of Zoom for moderation and to be asked. Please do follow up with our speakers with additional questions and solutions. These folks are leaders in the field and they're happy to answer any and all questions. And please send future topics, any comments, suggestions to our GEM mailbox. That's gem@pnpco.com. And thank you very much for participating. Details and recordings of the link will be available on our webinars page. You can scan this 2D barcode, or if you go to the Journal of Emergency Management website, you can actually, there's a page with all the webinars on that. Also look for a short post-webinar survey, which is very important for us to get an idea of how we're doing, what we can do better, and what topics are important to you going forward. This is a medical disclaimer. Some of the things we're going to discuss today are very, very difficult. And so the opinions of the panelists and the moderator are their own and are not to be considered medical advice. If you feel you're in crisis now or in the future, please immediately contact your healthcare provider or one of the resources below. This is very, very important. This is a very important topic. We realize that it can be very upsetting, and we're here to help. So at this point, I would like to introduce our moderators, and bear with me a second. I'd like to introduce Sonny Patel and Kim Guevara. Sonny is a former NIH Global Health Scholar and was named one of the top dev disruptors in mental health in USAID in India. His extensive disaster research background and experience includes his current work as a Harvard Fellow and an international research scholar at the University of Sydney. Kim is the founder and CEO of Mosaic Solutions. She has 25 years of experience in emergency management, telemedicine, and humanitarian development. Her diverse consulting career and numerous disasters and crises she has responded to have driven her to focus on preparedness and resilience to include the creation of the crisis athlete. So at this point, I'd like to welcome our moderators and all of our panelists, and thank you so much for all of your hard work to bring this presentation forward. Sonny and Kim, take it away.
Thank you, Richard, and welcome everybody. I'm Sonny Patel, and we're excited to have you here with us. We have such an incredible lineup of just well-seasoned leaders in emergency management and in mental health joining us today. As Richard mentioned, it may be a difficult topic, but much needed to discuss today. And so we're going to get through all your questions, discuss the state of mental wellness and emergency management, especially surrounding COVID-19 pandemic and the concurrent disasters that have been happening during this pandemic. But we have a lot more on deck, right, Kim? And what else we got?
We do. We're excited to be here to begin to talk and change the conversation around mental wellness and to really work for systemic change in this field. We noticed the enrollment numbers just radically increased very quickly as soon as the blast went out from the Journal of Emergency Management. Clearly, this is really resonating. We just want to cover a couple of admin notes as we go through. And then also, just as would be typical with anything, we're kind of pivoting here. One of our panelists just lost power, so true emergency management. And another one, Carolyn Harshman, unfortunately this morning, she took our statement to break a leg a little bit too literally, and she's on her way to the emergency room. So Sonny and I are gonna just kind of keep it going here and rolling, but a couple of quick admin notes. I think everyone's kind of seen it. But as you go through, please drop any questions you've got into the Q&A. We are monitoring. We're gonna attempt to get as many questions as we can answered today. You've also seen a couple of those polls come through. We'd love for you to go ahead and take that and submit your thoughts. We see this as a conversation, and you know, we all need the data. So if you can humor us and participate, we greatly appreciate it.
Thanks, Kim. And yeah, we're gonna do our best to keep it conversational, make it worth your time through and through. And speaking of that, maybe we should push our next poll as we bring up our first kind of speaker at Harvard medical professor, Eric Goralnick, to lay down the foundation and the overview of stressors. So for those that may not know, Dr. Eric Goralnick, he's the medical director of the Gillette Stadium for the New England Patriots, and also the medical director at Brigham Health Access Center and Emergency Preparedness. Eric is also, if we're collecting titles and experience, he's also the medical director for the vaccine operation at Gillette Stadium, which is the Massachusetts first mass vaccination site, along with many other mass vaccination sites that he has done and his team has done throughout the state. So to start off, and we got the poll up, which is great. We'll ask Eric to kind of join us with unmuting and joining us on camera. And you know, to start off, let's talk about the general and the pandemic specific stressors and challenges in emergency management. Eric, are you with us? There you are.
Yeah,
I'm with us.
Sorry,
Oh,
can you hear me, Sonny?
Yeah, we can hear you perfect. I think we're getting the camera up.
Thank you.
Yeah.
Okay, the host let me join my video, so I'm good. I'm here with you now.
Yeah. You know, no matter how long we've been in Zoom during this pandemic, we're always learning. They keep updating new updates, so it's great. It's great to see you. Great to hear you. Speaking of seeing, you know, we're talking about the pandemic stressors and challenges. You in the midst of it all and doing so much. You know, what do you see, especially when talking about mental health? What are some unique stressors in emergency management based on your experience? What some of the literature and some of the science tell us?
Yeah, thanks so much for inviting me to this wonderful webinar and series that I look forward to. So it's okay not to be okay. And I think traditionally in the military, for example, I was in the Navy for a while, or in public safety professionals like emergency managers, EMS, fire, emergency medicine, whatever it may be, we wouldn't talk about it. And we all see things that are challenging. And there are a lot of factors beyond our control. And they are challenging to navigate, whether it's a shift as an emergency manager in any type of setting, or an emergency medicine doc, or any of those public safety professionals I listed. But I think in the last few years, we've seen this emergence and encouragement where we've had individuals, public facing leaders, or celebrities, or actors, or politicians that have a voice, and they've used that voice for good and stepped up and acknowledged it's okay not to be okay, and talk about their challenges. You know, as the poll indicated, many of the individuals on this webinar are emergency managers. So I don't need to tell you about the stresses and challenges that you have on a routine basis. But it's okay to talk about it and share. And I think what we saw early on with this pandemic, some literature out of China with regard to healthcare workers, and incredibly high rates of acute stress reaction, or post-traumatic stress, or other types of issues, and a lot of terms, by the way, that people use for these various issues, but stressors. And we saw that early in China. This pandemic is one of many pandemics, let's say, that has caused this ripple effect. And you know, there were challenges around burnout, another popular term these days, prior to the COVID-19 pandemic. And this really has exacerbated, I think, in many sectors, this issue of burnout. So we've seen polls within the healthcare professions, particularly different subspecialties, emergency medicine, nursing, for example, or emergency medicine, other clinicians, physicians, and across the healthcare sector, where burnout, unfortunately, has been amplified, where we're seeing rates of, I've seen surveys, 30 to 40% exhibiting some form of depression, 10% suicidality, and all sorts of extremes across the board. And while I have not seen a lot of data with regard to emergency managers specifically, I think we can all extrapolate and think that many of those types of numbers probably apply to emergency managers at a minimum across the board. And so when we think about this, and again, I'll defer to our wonderful panelists who have expertise in a wide range of subjects as we build out this conversation for the next hour or so. You know, there are a lot of terms. There's resilience, there's burnout, there's moral injury, grief, acute stress response, post-traumatic stress disorder, post-traumatic growth. And each of them has unique challenges, definitions, unique sort of issues to navigate. And you know, I think a couple of the key ones to consider are burnout, which is really a product of chronic workplace stress. And it's characterized by exhaustion, negativity, reduced productivity, hopelessness, cynicism, distancing yourself. And we see that manifested particularly when we think of events that emergency managers would engage in, response, recovery, preparation, mitigation from all sorts of events, smaller events ranging to large-scale disasters. This pandemic, in its length, global impact, and range, has really set a new level where we see, as Richard shared with me, some of the numbers of emergency managers leaving the community because of many of these issues. So it's really a crisis across the board for all of us to consider, and a lot of that, I think, gets back to this moral injury concept, which is it's an injury where we recognize we are unable to provide maximal care for individuals. In our case, we're unable to, an emergency manager's problem set, we're unable to manage all the pieces of the scenario because of limitations that are beyond our control. And this is witnessing events, learning about events, and that could include guilt, shame, outrage, and moral injury is real. And it's something that we've got to recognize and talk about as a community and help each other navigate. So I'm really thankful for this opportunity. I'm eager to learn quite a bit today from our panelists. I'm eager to join for future webinars and learn both in print from the Journal of Emergency Management and learn from you how we can work through these challenges of burnout, moral injury, and help each other navigate not only the COVID-19 pandemic, but the pandemic of moral injury, the pandemic of burnout, and work towards becoming resilient together. So thanks, Sonny.
No worries. Thanks, Eric. And for those, we are limiting the noise, and Eric's currently on shift, so we appreciate him taking the time here. And you might be hearing the beep from his office. And I think Eric's doing his best to reduce the outside noise, but hopefully everyone was able to hear him. Eric, I'm going to have one follow-up, and then I'll kick it off to Kim to ask the rest of the panel. And again, those that are our attendees, feel free to drop in any Q&As for Eric from anything you're hearing. The first follow-up, Eric, you talk about moral injury, and one of the purpose of today is as we understand and identify those stressors and challenges that we have in the emergency management with the pandemic and concurrent disasters, we're really looking at what are some meaningful solutions-focused conversations, what are some potential systemic professional changes that are needed in emergency management to manage, the moral injury, the mental wellness side of it. Do you have any ideas or thoughts, based on things that you've done, with the mass vaccination with Gillette, with your team, that might be some good place to begin these conversations with?
Yeah, I think there's sort of short and long-term management opportunities, shall we say. I mean, we're all challenged with this. And some of it is around recognizing your multiple roles, as in this case, as an emergency manager, as a potential advocate with others, and a peer with others, as a family member and a colleague. The challenges of each of those roles, and then those compounded on each other. So thinking through each of those roles as a whole, individually, and trying to navigate each of those because they tend to overlap. And so pausing and thinking through each of those, how you can, in a constructive fashion, navigate each of those. And then the other pieces are, recognizing, providing context, recognizing limitations of the system that you're working in. We can't do everything. What can we do? Can we focus on those pieces? And that goes with identifying resources, whether those resources are within the system you work in, interpersonal relationships, your peers, peerage, right? Thinking through those pieces, your coworkers, your leaders, those that work with and for you, and individually. What are your resources as an individual that you could go to that bring you strength, that bring you comfort in times of stress? And that may be a variety of different ways. That could be with language, that may be with other types of things like expressive arts, whether that's painting, music, athletics, and ultimately, and I'll say the final sort of contextual processing is again, peerage, your social network, your battle buddy, your frontline buddy, the people that you really trust, and can have real conversations about real things that are really hard. Those are all potential strategies that we can all use at and overlap in a variety of different scenarios.
Thank you, Eric. I appreciate that. Great insights. We have some questions coming in while we get those through. Kim, I'll bring you back in. There you go. Perfect.
All right, everyone, thank you so much. And thank you, Eric, for those great insights as well. And we want to ask the rest of our panelists here kind of that same question. We just saw the poll results come up. 80% of people are feeling more stressed than before. I know from our work, the stress levels that we found pre-pandemic were exceedingly high. So now to, find that that's even higher, that's kind of what we're hearing. So we want to ask everyone here, and really, I'd like to thank all of them for making the time today. So if I can ask my panelists to turn on their cameras and their mics, we're going to go ahead and bring you up. First up, I'm going to be asking Jill Raycroft, the first kind of question here. Jill is the Deputy Director of Emergency Management for the City and County of San Francisco. She has more than 15 years of experience in emergency management, and for the past year and a half, she served as the planning section chief for the city's COVID command center. She is also currently leading the center's devolution and transition back to the city EOC. Jill, what do you think the stressors are that are unique to emergency management?
Yeah, and I really appreciate what Eric has shared. It really resonates with the work that I've been doing and seeing. So our COVID command center has been activated since July of 2020, and before that we activated an emergency operations center. The current structure that we are working to transition back into an EOC and department structure is comprised of about 1,000 individuals. We technically call these folks disaster service workers. I think through our FEMA doctrine and construct, we've worked really hard to train individuals in the city and county of San Francisco. But what I have noticed is a lot of these folks are just really passionate people that want to help. And I think what I have seen, a couple of things to your point, Kim, and what Eric, I'm going to kind of dovetail on what Eric said. So the burnout was already there. So in the city and county of San Francisco, we're obviously in the state of California, we had the worst wildfire season on record. And we're slated to have this year to be worse than last year. So we had just come off of helping to respond to that. So what San Francisco does in a wildfire situation is we support other counties with sheltering operations. We are an urban interface, but generally the wildfire is not going to come to us. So we were already burnt out. We tried to take a breath, and then in January we activated for COVID. So we haven't had a break. So to your point, Eric, about this burnout, I think the best thing that we've been able to do in our 1,000+ organization that's comprised of medical professionals, disaster service workers from a lot of our operational departments, NGOs, private sector, is to just talk about it. I think having this conversation is the start of it. If we can name some of our issues, if we can name some of the problems that we're seeing, and if we can also be vulnerable and honest as leaders and say, I'm tired too, and it's okay, I think that's a good start. Some of the changes or maybe anomalies of this situation, Kim, is that we get trained to be in an EOC for maybe 10 days to 3 months. We are not trained to be in an EOC environment 12 hours a day, incident action plans, meetings, and all the stressors that go with being an emergency manager for over a year and a half. I've never taken that FEMA class. So we've had to build the plane as we fly it. And that has been both really important and instrumental to building trust in our organization, but it's also been really stressful. We did not have a template. We had a really good pandemic plan, but it was not about a global pandemic. It was about what happens if San Francisco, the state of California, or the US experiences this. So I would say that, leading with empathy, discussing, especially at the highest level when we're having a hard time, leading by example by taking time off. Those are some things that we've had to adapt and change culturally. I think the culture of emergency management is we are crisis athletes, as Kim knows. We go, go, go. We really care. We want to help. But our public health colleagues have actually helped us slow down and really look at how we're doing. So I think that that's been a really great partnership.
Thank you so much, Jill. And I can't, from talking in the conversations, like just the pace that you've been at is just relentless. So thank you for being here. And I know you're like boots on the ground, and those insights are really great. I think especially that culture piece, right, is such a huge thing in this field. We set that pace for ourselves and those high expectations. I'd love to ask Vince Davis now that kind of same question. Vince brings cross-sector experience in the government, nonprofit, and private sectors and building crisis and business continuity programs from the ground up. His experience includes FEMA, the Red Cross, Walgreens, Sony, and Amazon. And then fortuitously in January of 2020, he made the leap over to Feeding America, where he thought he might have a quieter experience, only to find that his expertise and experience was invaluable as that organization faced its greatest challenge yet to meet the pandemic-related feeding needs. So Vince, same question for you. What stressors do you think are unique in emergency management?
Thank you, Kim, and thanks for having me on the panel today. I'm really happy and thrilled to be here. As you said, I think one of the typical stressors that we all experience as emergency managers is, of course, managing our own world. But in addition, I think the additional stressors for us as emergency managers are the fact that we're often the emergency managers for our own families and our own personal lives. We're the person who everybody goes to when there's a crisis in the family. And so in addition to dealing with our work life, if you will, and as I started at Feeding America in January of last year, trying to get our arms around the existing challenges of 200 food banks feeding 37 million people to now losing 50% of our donations and having to feed more than 60 million people, is also the personal. And for me, the personal was very much more stressful than probably any situation that I've ever been in. In September of last year, I lost my brother to COVID-19 down in Florida. At the same time, as a matter of fact, on the same day that my brother passed away after a valiant, 3.5-month battle with COVID, my wife went into the hospital for a major surgery, literally on the same day, the same morning that my brother passed away. So not only was I dealing with the stress of family issues, but also dealing with the stress of work issues. And so I think that unique challenge that emergency managers face, that we face as emergency managers, has to do with trying to fight the battles on both fronts, if you will, on the personal and on the professional. And as we move through those issues, we have to understand that we're not bulletproof. I like to say we don't have a bulletproof soul. We are as vulnerable as anybody else to both stress and grief and all of the anguishes that go with the work that we do. But sometimes I think we're the ones who lose sight of that, and we don't really practice what we preach, so to speak. I used to teach disaster psychology for CERT teams here in DuPage County in Illinois, where I live. And I would often talk to people about, critical incident stress debriefings and the importance of self-care, but I wasn't practicing self-care. 2010, after coming off a regional catastrophic planning effort of 14 months for the evacuation of 1 million people in Chicago region, and all of the daily stresses of my life at that time, my dad passed away. In the meantime, I suddenly woke up one day and found myself unable to move, couldn't breathe, literally could not get out of bed, and could not, face another challenge of any kind. And it caught me so much by surprise because I had never been in that state before. So I think for us, the stressors, as you asked Kim, are much greater because of the expectations and the weight of the expectations that are on our professional lives as well as our personal lives.
Thanks, Vince, so much for your vulnerability and for sharing all of that too. Like, it's just incredible, and having watched you kind of go through that, at least through this public sharing that you've been doing. It's really humbling. And I think that's why we're here, to have that conversation, because so many of us don't talk about that. And there's so many of us that have burnt out, and we're not talking about it. We're not sharing it. How do we change that conversation for the next generation of emergency managers? Because there's some chat that's been coming in and questions about how hard this is as well on our families and our relatives to be that. We're the ones that are still called to go and to be there for everybody else. But we still have our own families, our own relatives, our own needs that we have to take care of. And oftentimes those are neglected. And we're not doing a good enough job at the organizational level to do that. So that's what this webinar is for. So Thank you so much for that, for sharing, and Jill as well for all of your vulnerability. I want to turn now to Dr. Chris Stout and ask Dr. Stout, who is a clinical psychologist and the founding director of the Center for Global Initiatives. He's had a diverse and entrepreneurial and academic career. He's published and presented over 300 papers and 35 books. He's been interviewed by Oprah, CNN, CNBC, Time, the New York Times, and many others. And Chris, same question, and building off of what our other panelists have said, what stressors do you think are unique to emergency management? You know what? We actually, okay. Chris is gonna come in via phone here because in the middle, he lost power, true emergency management style here. Chris, please go ahead.
Hi, Kim. Can you hear me?
We can. Thank you so much.
Oh, well, hooray. Yeah, a little in vivo desktop experience here, like literally just quickly to say that I was sitting here in my study and the lights flickered and my computer screen went black and my little Wi-Fi quit blinking. So I appreciate, sorry for the little hassle here, but hopefully I can at least stay on via phone and we can make the PowerPoints work when we come up to that point. I'm humbled and honored to be part of a talk like this. I think it's incredibly important, and I think what Eric and Jill and Vince have shared with us so far is very emblematic of what good leaders do in these kinds of situations. Vince, in particular, I am touched, my friend, about the stresses and hardships that you had to endure through this. And I think it circles back to, I think a lot of people, you know, in the emergency management area, there's sort of, for some reason or another, and this maybe is just my stereotype, but it seems like there is a stereotype about we have to be these tough stoics. We have to be able to handle hell and high water. We have to, you know, kind of become these sacrificial folks for the benefit of others. And while, you know, maybe that's part of a piece of a humanitarian spirit, which I think everyone shares on this webinar, oftentimes what gets lost in that is that we don't necessarily, you know, help keep track of ourselves or our families, you know, or each other as colleagues. And I think it sort of speaks to, you know, again, just the people publicly sharing in a way like this of ways that leaders can step up and talk about these personal experiences. If we don't talk about what's going on in our home lives, what's going on perhaps with our own anxieties or areas that are obviously for all of us brand new to us having to deal with this, it's good to have the preparation. There's things that we've, you know, techniques and methods and approaches that we've all used, but oftentimes we then forget to use it with our own teams and our own staffs and our own departments and our own organizations and ourselves and our families as well. So one of my hopeful things after we start to get to the other side of this is that we pay attention to what we are starting to do now that I think is helpful and adaptive, and that we, I hope, come out a bit more strongly interdependent with each other, that maybe some of our teams just through the crisis have become more adaptive, and these are things that we can start to use in better lines of communication, better lines of sharing, more normalization of being, you know, people sharing their honest concerns and perhaps what they thought, you know, was inappropriate, like what's going on in their personal lives, that, you know, it doesn't have to take a pandemic or a crisis to have opportunity to be able to talk about these things and a space in our organizations, in our departments to be able to bring these things up. So I'm hopeful that once things start to settle down, that we won't stop doing these things that have been adaptive and have been helpful to be able to get ourselves and our staffs through this.
Thank you so much for that. I think that's so true. Like, we're starting that conversation, and what I hope is that so much of what we're starting here and having these honest conversations is it doesn't just become another kind of lesson learned or lip service that we pay, but we're actually really working towards change, which is the great thing about this webinar. Right now, we are going to go ahead and we're going to take some audience questions that we've had coming in. So this is a question, I believe, for to all panelists, and we can see who wants to take a shot at it. I want to get your thoughts on how we manage uncertainty, how we're able to speak to uncertainty in terms of the short term, like that daily juggling of the urgent priorities, and then the long term, like as we look towards the pandemic ending and recovering. That question came from Jasmine Song. Jill, maybe I can actually ask you, because you're dealing with the planning section over in San Francisco, the inputs, 1,000+ people on staff, and all these different novel problems, and then the complexity. How do you juggle and prioritize, especially within your role? That's your job.
Yeah, and Kim, I actually just took over as Deputy Incident Commander for COVID, so it just keeps getting easier.
You do a good job, and that's what you get, right?
Yeah, right. Yeah, so I think this is such a great question, and it definitely goes back to what Vince was saying and others, that communication, that vulnerability. So at the COVID Command Center, which is currently housed at our convention center in San Francisco, we have a weekly all hands meeting. So the tech sector really pioneered this, especially at Apple, where you get all hands on deck, you get everyone from the company or the organization to hear from the leadership. And this started when we started the conversation about how are we going to engage these 1,000+ people in a meaningful way. There is a lot of, management by walking around, looking at people's eyes, seeing how they're doing. But, how do we get the folks that are really in charge at the policy level to instill trust and also share transparently what's going on? Because this is a public health emergency and it's steeped in science, there's a lot of data that we can share, but we always have to contextualize it. So we were talking, Kim, I think the question is about how do you manage uncertainty in the short term and long term? So we just went into the yellow tier in the state of California. That's a better tier than what we were at, but that also compounds a lot of our reopening efforts in the city and county of San Francisco. So as far as communicating short-term uncertainty, what I've tried to do with folks in our advanced planning section is to really look at how can we use data and modeling as a tool in our tool belt to communicate this is the path we think we're going to go on, but caveat that we need to be open and flexible to changes. And we have seen that time and time again. I think also just, having meetings. So our all hands meeting looks a lot like this. We have our executive leadership speak to everyone. We take questions from the chat. We give them our email addresses. We say, I sit in this room at Moscone, come find me. I'm a resource. So I think that is a way that we try to juggle uncertainty, and also just having as many crucial conversations about some of our fears around what's going on. So that's in the short term. The long term, we just had a presentation at our policy group this morning from the woman that really manages modeling and statistical analysis at the University of California, Berkeley. So she was able to give us, again, models and information and data about where she thinks the city and county of San Francisco will go if we take certain actions. The caveat is, again, the flexibility. We are in a state of, relief right now that a lot of our residents in San Francisco are getting vaccinated. We obviously have the issue, like a lot of counties and globally, really, with folks that are unsure about the vaccine. So that's our next step. So it's kind of it's not a choose your own adventure, but through our modeling, through our data, and through our conversations, we're able to say, if we do this work around this piece, we're hoping that the disease will switch in this way. And if we don't, this is what could happen. So it's really that creating space for people to bring up concerns using data, using modeling, caveating that it is not definitely, that clear-cut answer to everything, but really giving people resources, time and energy and space to discuss the path forward.
Thank you so much for that great answer. And I love, some of the words you threw out, right? Flexibility, the planning meetings, the accessibility, the crucial conversations, like all of those things, which I know is even more pressure on you as a leader in emergency management as well. Right now, we are going to pivot just on a time basis. I feel like we can spend so much time talking about all of this for so long. And so I'm going to kick it back over to Sonny here to bring up, bear with us here as we kind of work with tech with Dr. Stout here to catch up, but Sonny, take it away.
While we get the tech going, I wonder if we can sneak in one question. Eric, if you're there, let's get one question in. I just want to get this in. This is a very more clinical question, looking at the trauma exposed to working with inadequate PPE. And I wanted to maybe, the audience was a question from the audience asking about coping skills that deal with stressors, which Chris will talk a little bit in his presentation, but maybe we can have a quick question if you can ask about the trauma exposed by inadequate PPE, and maybe if there's anything that you see in the literature, coping or dealing with the circumstances from inadequate protection against biological harm.
Yeah, it's a good question. Thanks, Sonny. There's a long history of challenges of not having the appropriate gear for the job. That goes back quite some time, at least in the 20th century. Think of miners and the potential impacts of miners not having appropriate respiratory equipment, which subsequently led to development of the SCBA, which is equipment that was developed by the Navy for firefighting on board ships, and developed for miners and their respiratory protection. Think of asbestos on Navy ships and the challenges associated with that, and either using those types of materials that potentially could lead to mesothelioma or others. World War I, we could think of all of the chemicals that were used during that event, and the lack of adequate personal protective equipment for individuals. In fact, World War I and led to subsequent compounding of a spread of the last pandemic, 1918, in that time frame. So to think about all of those impacts. So there is a history of not having the right gear for the job. What do we know about the mental health impacts of not having adequate PPE? I don't know that much. There may be a fair amount of literature out there, but I'm not aware of it. I defer to others who may have that, and certainly can take that as a follow-up. I would say that as managers, as emergency managers, acknowledgement of that, especially going back to the first question, the uncertainty we've had at the beginning of the pandemic about this new disease, how it's spread from person to person, and questions of contact and airborne and all of these challenges, and what type of PPE we need to use, compounded by the lack of PPE available. Really going back to the basics of planning assumptions, understanding those challenges, understanding there is uncertainty, and so defaulting to the safest possible care you can, and optimizing the systems to help individuals as opposed to fault of an individual. So thinking of a just culture, building a system to help individuals navigate these challenges.
Thanks, Eric. Thanks for that. And Chris, are you still with us on the line? I think you are. We're trying to get your slides up. I think it ties in nicely to that other part of the question, which was looking at the coping skills and stressors. And Chris has a great slide deck for us to walk us through with some of the stressors there, but also about the coping strategy and interventions, which some of the attendees already asked these questions in the chat box and in the Q&A. And please do keep your Q&A questions coming in. We're answering them live, and then those that we can't answer live, we'll start typing in the answer. But we're really planning to make this a conversation to answer it live. And there we go. We see the slide coming up. Chris, are you there still? Can you unmute, and then you could just walk us through that? We have your first slide deck up, I believe. Yep. Okay, Chris, we got your first slide deck up, and thanks everyone for the attendees. There, go for it, Chris.
All right. So you've got audio on me?
Yep, we hear you clearly.
Okay, great. Okay, so This is a great demonstration of improvisation and adaptation. So, Sonny, I may need your help just to make sure that I'm going to kind of run the PowerPoint off my battery off my desktop or off my laptop, and then I'll just kind of cue you for those. So the next slides, and hopefully we can kind of stay somewhat synchronous here. So first of all, just again, thanks to be able to share a few slides with this, and this will really just be the tip of the iceberg. I understand we hope to have other meetings and maybe go into further depth on some of these. And I'll have some resources that people can reach out to as well at the end of my little deck. As I sort of mentioned earlier in some of the discussion, was the stereotype of being gung-ho. In the work that I've done, I've worked with people that are have a very big heart, are very oriented to helping others, and I've worked with people that then get themselves involved in a situation. I had a person in particular early on in this kind of work that had been at the Peace Corps and just really had a traumatic experience by being exposed to people that she was very well trained to work with, but by seeing them and working with the less fortunate. I had one of my first medical missions that I went on in Vietnam. There was a very well-trained physician, and I got a knock on my door before we were heading to Ha Long Bay. We were in Hanoi, and I got a knock on my door one evening from the leader of the group, who was like at 3 in the morning, saying that there's a crisis. And long story short, that the individual just was not used to being away from home. Was feeling somewhat traumatized by that, and the fact that we were just going to get further and further away, is increasing that person's anxiety, and the best intervention was to get that person back home. So I think sometimes in the overarching aspect of what we've been talking about in the context of COVID and pandemics is that there's a feeling of the unexpected, even when you might feel like you're prepared. We've all been through trainings. We've all got, whatever, experiences and things by virtue of that, as well as academic training. But when the unexpected happens, and then we feel like we have a lack of control over it, it creates the risk, certainly creates stress and the risk of trauma. Sonny, can you pull up the Romeo Dallaire slide?
Yep, I believe that's up.
Great, thank you. So some of you may know this story. I like to point it out, and would really, if anybody wants any links to hearing him speak, he's just an amazing individual. The quick backstory with him was that he was a lieutenant general, military guy, had certainly been through a lot of hardships, seen a lot of horrible things. But when he was taken to Kigali, Rwanda to work there, as a peacekeeper for the United Nations, the trauma that he was exposed to of what the civilian population was going through sort of impacted him at a level that was greater than anything else he had ever seen in his 30-year career. And he was probably one of the first people to kind of come out and get beyond this traditional, because I've also worked with folks in the VA, there's kind of this need to feel like you're gung-ho, you can kind of parachute in and handle any kind of situation and fix things. And he was seeing that this was not the case. And he came back and publicly talked about his experience with that in the context of his own personal PTSD, which again, I think, when I was speaking earlier, people on this presentation sharing their own personal experiences, I think goes a long way to destigmatizing those feelings and to not feel guilty about having those kinds of feelings. Sonny, next slide.
Go for it.
So with this, thank you. With this too, you might know the story of James Orbinski, also still focusing on Rwanda with this. James also is a physician, ER guy, had been in a lot of war zones, former and active, working with injured civilian populations. And similarly, he kind of came back and went through, and this is a documentary that I would certainly encourage people to watch, and talked about his experiences. And in spite of years of training, years of dealing with these kinds of things, there was just something uniquely different for both these gentlemen with regard to their experiences in Rwanda. And he came back and shared those kinds of things. I'll make mention of this in a couple of slides or two, but Sonny, could you pop up our next one? So while it's good to have, you know, these, they're horrible experiences, but it's, you know, you have to be impressed with the work that these people do and that you all do. But in the context then of being able to say, you know, I'm not bulletproof, you know, don't have the, I like that, Vince, the bulletproof soul aspect. And burnout is not anything that's new. Burnout's been looked at, you know, for decades. It's sort of hard to kind of define it, but basically some people just kind of refer to it as sort of like a challenging relationship with your work. It can be a variety of different non-specific symptoms. The causal drivers can vary for each one of us. It's been looked at and researched. I mean, if you just Google Scholar, you know, burnout, you'll see a variety of different experts and specialists publishing on that, you know, with a literature that goes back 20 years. But, and we see it in particular, my focus is looking more so in terms of healthcare practitioners, of these high levels of the expression, perhaps, of their stress going unmanaged, or at least at a level that's not satisfactory, with high levels of suicide rates, as shown by this. Sonny, next slide. So, in spite of all of the research that's been done, in spite of a lot of very bright people focusing on this, we don't see these things pulling up. Sonny, next slide, which should be a pop-out. As recently as about 3 weeks ago, JAMA, Journal of the American Medical Association, published a study looking in particular of U.S. nurse populations and found that female nurses were dying at a rate twice that of the general population of suicide. So again, there's a lot of epidemiological work done on this, and we're seeing this, but great interventions. You know, there is not a quick fix. There is not a one size fits all for this, and it continues to be, you know, if you will, a public health crisis. Sonny, next slide, please. So, you know, what are we looking at? Is it depression? Is it stress? Is it PTSD? Is it anxiety, burnout? Moral injury is coming more to the fore of this, not just for veterans populations, but other people in similar kinds of facing of trauma. And, you know, I think it is kind of, you know, all the above. No matter what someone may call it, it doesn't necessarily rule out something else. I think the point for all of us in terms of each other and in terms of managing systems and departments is to take a look at kind of two general areas. The risk factors in this can be situational or systemic. Oftentimes there's been surveys in the literature that say that people have felt that perhaps a leader hasn't been supportive to them, or maybe there's a failure of empathy there. After an event has ended, there maybe isn't a debriefing, a post-circumstance look back of it in terms of what went well, what didn't go well, what can we learn from these kinds of experiences. Similar to what I mentioned before, oftentimes people feel very well trained, but maybe they lack the authority, or they lack the latitude or the autonomy to make decisions on the fly, or they get, you know, silenced from trying to get permission to do certain kinds of things that then compound and impact the problem, but then also their hurtful, negative experience of that. As we just heard, you know, from Eric dealing with this question, you know, the lack of protective equipment. You know, we have concerns for ourselves with that, and then are we, you know, going to become vectors and come home and infect our loved ones with it? So, which are atypical kinds of situations and a lot of the things that we've been dealing with that aren't pandemic related. And then the double bind of that can create an immense stress, a cognitive dissonance of knowing how to care for a patient or how to care for a population or whatever the intervention is, but not being able to do so because of a constraint or a limitation. It's not uncommon to see things, people posting, Twitter in particular, you know, about feeling like their emergency department is now turned into a de facto ICU, and making decisions about who gets a ventilator and that type of thing isn't typical for someone in an ED, for example, with the pandemic. Looking at the individual, oftentimes they feel unaware, unprepared for the psychological aspect. They may know the technical, they may know, you know, exactly, you know, what to do to put the fire out, so to speak, but then aren't necessarily, you know, they perhaps might be surprised with the impact that that's had on them. Some people, in particular, like we've heard today, you know, if you have traumas that you're dealing with in your own family, your own circumstance, that diminishes your ability, your resilience to be able to deal what you then need to do when you have to put on your game face and go deal with things in an external level. Things just add up. Things mount, stresses mount if there isn't some kind of pressure release, and it leads to overwhelm, which leads to further stress, which leads to poor decision making. And again, the lack of control is kind of the flip side of the coin of helplessness. And again, this just exacerbates anxieties, and all of these things certainly do not energize us, but lead to fatigue. Sonny, next slide. So let's take a look and click again to open up those interventions. So hopefully we're seeing cognitive behavioral therapy and some of its variants. With cognitive behavioral therapy, I think it has a great appeal to people. A lot of my work academically has been in evidence-based practice and treatment outcomes, and there's a very large and ever-growing robust literature on the efficacy of cognitive behavioral therapy. I have a bias. That's the practice that I use and that I was trained in, but also in being fair to looking at other things, I have a prejudice that I think it also fits well to the mentality, the general mentality of people that are that do emergency work. It's very technique oriented. It's very specific. It's very here and now. It's very method and adaptive and gives activities of what to do. That's not to say that other kinds of psychotherapy, like traditional psychoanalytic techniques or things that might look back at a person's history and stuff, don't play a role. That's an individual by individual basis. But in terms of people that like techniques, like more time-limited kinds of approaches to things, again, cognitive behavioral lends itself to that. In particular, I just sort of picked these three. They're kind of newer on the scene. Cognitive processing therapy, which has been specifically used for various kinds of PTSD, everything from child abuse to rapes, natural disasters, combat. So those are, again, use some of the same techniques of cognitive behavioral therapy. It's time limited. It's kind of manualized in 12 sessions. ACT, or adaptive and commitment, acceptance and commitment therapy, is again a CBT variant. Its focus is on diffusing negative thinking and unnecessary dwelling on negative emotional things. Uses a variety of behavioral techniques, and then adaptive disclosure is a very brief manualized type of psychotherapy. It's been developed generally for people in the military, but also has been now greater literature looking at life-threatening experiences or traumatic loss or moral injury. And Sonny, next one, systemic and leadership. So again, as has kind of been mentioned already, and I think we've gotten great examples of this from Jill and from Vince, but just to say, what are some of the things that we can take a look at in terms of being leaders, being department heads, being consultants, whatever our work may be and doing individual leadership ourselves in terms of how we comport ourselves, but taking a look at being sure to, and we've heard this, I think that, you know, Jill, you've kind of learned this from some of your experiences that you described in your San Fran issues of, you know, giving space for feelings, talking about those in teams, for all of us to develop and support developing clinician-centered or provider, I should say, I'm thinking medical, but provider-centered care-focused leaders, strong, interdependent, and adaptable teams and communities. You know, how do we go about doing that? Do we create a hotline for ourselves? And that hotline doesn't necessarily mean a 800 number. It can be just going into our leader's office, being able to develop a team where we can say, hey, I need to blow a whistle, call a timeout, and we can all come together because I'm feeling a little shaky right now, or our teams are needing some extra support than what's typical. Being open to mental health appointments and making the space and time for people to do that while, you know, respecting their privacy and boundaries. And then making sure that psychotherapeutic services are available to them. That might even be just talking to human resources and seeing literally what people's benefits are for that, so that they don't feel any kind of ambivalence or not choosing to reach out and do that. And telehealth has exploded during the pandemic. And Sonny, last slide. So what should be coming up is just other resources. Sonny, go ahead and click on that. What hopefully is popping up is a kind of a white bar with little examples in it. Thinking about looking at there are a variety of mental health resources that are available out there in all shapes, sizes, prices, and forms for people. For healthcare workers, there's a variety of different kinds of guidance out there to look at leadership, dealing with moral injury, nice set of publications and a toolkit available. And Sonny, if you could click, hopefully will now be showing up that you guys are seeing what I'm seeing, is a link there for fixmoralinjury.org. And these are the resources. These are in particular for COVID, but I would encourage people to go there because there's an abundance of other resources there. And then Sonny, last click. There's also even a podcast that's relatively new, but I would highly, if you're into podcasts, I feel like this is a pretty good one. They do a nice longer form, deeper dives where they can actually unpack some of the issues. And I would suspect that for you or your staff, there's a variety of resources that the discussants and guests on this Moral Matters show will be very resonant to some of the experiences that you and your teams have been going through. And you might find support there. And also, again, just the whole aspect of normalizing this, that we're not in this alone, and other people have come up with very clever approaches with dealing with this, and we can learn from those as well. And Sonny and everyone, thank you, and I'll sign off with my slide deck.
Thank you so much, Chris. And again, thank you for not only your insights, but being adaptable with everything going on. We did our best to sync in, and again, those slides will be available or the links will be available and be shared when we do the follow-up with everyone on the attendees. And just to give a heads up, we'll be wrapping up the session in about 20 minutes, but we have a few queue of questions to get through. So we're going to bring all the panelists back up. And so with the cameras on and Kim as well, and Kim and I will go on and off video as we keep sorting out some of the questions. Again, keep the Q&A going. We're going to push a few more poll questions in, and then we'll bring it in to it. But again, I think I'll kick it to Kim, but Chris, I think you laid a great foundation to talk about these different levels of interventions. And so, and there's a few questions that are related to this in the Q&A. So Kim, I'll let you go with that.
Great. So we'll just give a couple seconds here for everybody to go ahead and respond to that poll, and then we'll bring up, throw a quick question over to our panelists. Richard, if you can tell us when you're ready to close the poll there and we can see those results, that would be great.
Just about another 30 seconds, if you don't mind. 15 seconds. There we go.
You got it. The countdown's on.
Got about 126 people who have voted. Thank you.
I love all the participation and these great answers, which are going to give us great items to go off and think about for the next webinars and kind of how we move forward from this. Also, as part of this, we've been talking about different surveys that we'd love to get out. I realize everybody's surveyed out, but we realize there's a lot of polls and studies. There's been several done. The Washington Post recently did a survey on healthcare and first responders. There was another study by VAGNI that came out, and they're pushing information out about emergency responders, but there's not as much in the emergency management community specifically. And so we're really interested in tapping that. And, there's, interestingly, we still have 66%, they have not considered leaving emergency management, which is fantastic. But there's also 34% that have said that they've considered leaving. I know, everybody here knows somebody who's tapped out now as well. So we should really think about that, because the last thing we need to be doing is losing more talent from this field. One of our biggest challenges is how burnt out we are, is because we don't have enough people that can do this. So now I'd like to kind of pivot back to our panel here. And are you pushing another poll, Richard?
Yes, they were tied together, actually.
Okay. Apologies, we'll give everyone another few seconds here to answer that poll.
You want to talk through this question, Kim?
Sure. Do you have support systems and staff in your organization to address mental health issues? One of the things that we've been finding is we're also really curious, and this is going to be a question that I'll just go ahead and queue up Vince here as we come and kind of pivot to our next question, which has a little bit of this tied in, given his experience in government, nonprofit, and then also the private sector. Are there any lessons learned or any different best practices that we can gain from either one of those sectors? Do you find that there's any one of them that is doing a better job than others? You know, so a lot of times people think people in the private sector, they've got more resources, they're able to do more. And then at the same point, you hear that it's more competitive, more cutthroat there. There's more support in government. And so just wondering from your perspective right now, if you found anything, or what have you found that works well in terms of support systems that we can do?
Yes, Kim, thank you. Well, having worked in those different sectors, I can tell you one thing that they all have in common, and that is that emergency managers tend to always be the glue and the go-to persons, the go-to individuals that hold those organizations together. An example is Sony. When I was at Sony, we had a debriefing on the Sony hack that took place in 2014, I believe it was. And the key crux there was that the emergency management folks at Sony Pictures were the ones who kind of stepped up and held everything together. So having all that in common, I don't see any major differences except for the fact that .orgs like the Red Cross and like Feeding America, NGOs tend to be more mission oriented, and therefore they tend to seem to be more in tune with the needs of their individual volunteers and employees because they're so mission oriented and so singularly focused. For example, at Feeding America, we've got a transformative leader in Claire Babineau-Fontenot who came into the organization a couple of years ago and has led us through this whole pandemic chaos as an organization in ways that probably few people could have. However, she is not from the non-government sector. She actually was the chief financial officer at Walmart before coming to Feeding America. So I think there's a lot to be learned from every sector in terms of how they manage these things. Government, tends to move on things a little bit more deliberately just because of the structures of government. I don't know that that's necessarily a criticism so much as it is a fact. But in general, I find that the real key to getting people the help that they need is having those transformative leaders that recognize the importance of keeping their employees' mental health in focus so that they don't have these mass exoduses of people and mass burnouts. I know when the doctor was talking about the nursing profession, that one hit very close to home with me. I have a daughter who's a nurse who left not the profession but left the hospital setting and went for a different setting because of all the stresses of COVID. So I can relate very closely to that. You got to have transformative leadership at the top that recognizes the value of emergency managers and others in their organization, and really focuses first on making sure that those people are okay, or as somebody said earlier, that it's okay not to be okay. It's okay to raise your hand and say, hey, I'm not okay. I've got a problem with this. I know you've seen a lot of my posts, Kim, on LinkedIn, where you said, I know Vince is not okay, because he wouldn't have said that in his post if he was okay. So I think that was part of my own personal therapy, is being able to express myself in a very public way and hear the responses of other people, because I'm not the only one that's going through these experiences. And certainly as I talk to people, especially during COVID, every other person you talk to has an even worse experience than yours in terms of coping with COVID. So I think part of that sharing in itself is therapeutical, at least it has been for me.
I think it's so true, Vince. And, thank you. And I think, we put so many people on pedestals, like, you and Jill, I look at you guys and you seem superhuman, but we know that's not. And so really sharing on that transformational leadership. We are getting close on time, and there's one more question that we want to ask you guys as we kind of do and wrap up, and we have a lot more follow-up that we know and work we can do on this. But Jill, just kind of, again, keeping it really brief, maybe 1 or 2 sentences, how do you think we can destigmatize mental health and mental wellness in this field? How do we make prioritizing this our new normal?
Yeah, so my opinion is that emergency management, it's constructed, it's socially constructed. We make it what it is. We do have doctrine, again, from FEMA and other federal agencies that try to, give us some guardrails for what we do, but it's on us. I mean, I think what we've done in San Francisco has been really wonderful, just discussing how we're feeling. I mean, it seems very simple, and as leaders, just being vulnerable. I think, Vince, I really appreciate that you have shared some really personal stuff with 500 people, but we need to do that as leaders. I think that that's the key to starting the conversation. And I think it's also, we're a city and a county in San Francisco. FEMA can help us, but a lot of this has to be done at the local level. We know our city and county employees, we know our constituents, we know our residents better than anyone else. And we have to customize what we need for that. So if this is socially constructed, we can deconstruct it, we can change it. It is in our hands to do that. I also just think that I saw the poll, Kim, where folks say, yes, we have resources for mental health within our organizations or agencies, but we need to do a better job of sharing that. And I think creating a space that is more consistent, every staff meeting, bringing up things like our employee assistance program and normalizing that it's okay to not feel okay. And it doesn't mean that we have to come into staff meetings and share every little thing that we're feeling or thinking if we're not comfortable with that, but that it's okay to take breaks. It's okay to get help. And I know this is not 2 sentences, but I think there's a lot to, but I think we do have a lot of power really to change this. And I don't think it's the matter of waiting for a top-down answer from the federal government. And this is how we will address mental health and emergency management at the local or state level. I think we just have to start doing that and talk to each other, share resources, and change that culture. It is on us to change that culture. All of us, not just the folks at the top, all of us, every single one of us.
Thank you so much for those insights. And, some of the questions that we're seeing and comments coming through too, is that it's not just necessarily the field per se, but in some cases, the organizations and the leaders. So I think that's really something that we can think about and grab on. I'd like to ask Chris that same question. If Chris, I don't know if you're still on the line and can hear us here. Dr. Stout, are you still available? If not, I'll give him a couple more seconds to come up here if we can. And Vince, ask you the same. Oh, thank you.
Hey.
I know, so hard here, right?
Sorry. Well, I just need to double underline and put a couple of exclamation marks behind what Jill's just said. I think it's really incumbent on us to work to destigmatize our own vulnerabilities. That we're not superheroes. We don't have the red cape. We have our own circumstances that we have to deal with. We also have our own, family circumstances, et cetera. So I think the quicker that we share our own vulnerabilities with appropriate boundaries, and do that with our staffs, do that with our colleagues, and then offer appropriate levels and proper types of systemic support as best we can with whatever tools we have to do that. And then to have communities like this webinar to be able to share best practices. Part of this is nice just to be able to have an opportunity to learn. I can't be alone. I can't be the only person feeling this way. And I think this webinar has gone a long way to sharing those kinds of things in a very nice and transparent way that people are willing to do. But then also, I've gotten new ideas hearing my colleagues today about this. So I think going on these ways and also going with the kinds of articles that we see in the journal, I think will go a long way to help giving us new ideas and being able to better manage with the resources that we have available.
Thank you so much, Dr. Stout, for those great insights too. I think really keeping the conversation going is absolutely key here. And that's what we're really kind of sought to do with this webinar today, was to start the conversation. Vince, how about you? In a couple sentences, how do we destigmatize mental wellness and make this our new normal in this field?
Well, I think, Kim, this is the start right here. As you just said, the start is having forums like this where we can actually talk about these issues, you know, in a very non-threatening way, and not wait until some incident has happened. You know, I'm waiting for the day when some, you know, emergency manager loses it and there's some horrible incident. I don't want that to be the thing that drives us to these discussions. So I really want to thank you and the panel and the Journal of Emergency Management for taking a leadership role in this area and bringing this to the forefront. This is the start of, I think, some very good dialogue and some very good solutions for what we're trying to deal with.
Thanks, Vincent. I'm just going to jump in because we're not off the hook yet. We still got a few more questions and minutes to get in, and I'm just going to, Kim and I are trying to push things through. I'm going to talk over polls just so we can keep it going. And one of the, I think the important, we had the conversation started and we have a lot of the research shared, a lot of the insights and experience, and thank you all for providing that, despite the challenges that we deal with the technology and power. And again, I really hope that the audience is really appreciating a lot of these nuggets that you've been sharing, these gems of knowledge. But so we had this conversation, and this is, we'll key into our next webinar, you know, but not to tease it out too much. Where do we begin in a conversation? One of some few audience members been sending messages, even to me on Twitter, on other platforms, of really making sure I get this question in. And, you know, so we talk about destigmatizing mental health, but how do we start that conversation? How do we, if you notice a colleague that's maybe not taking care of themselves, how do you start that conversation? Or if you're not feel like you're being taken care of yourself, how do you have that conversation to your bosses, to your colleagues, to think that, like, you know, I'm not able to go 100 right now. And I'm just gonna pick randomly Jill, and then we'll just go with others from it.
No pressure.
Yeah, no problem. Figure the EOC with all that experience there, Jill. I figure you probably have already like you know, a color-coded system to deal with this.
Oh yeah, it's all figured out. I mean, I think, you know, we've been fortunate, and I think I didn't see it this way in the last 6 months. We've been in person. I've been going to work every day, pretty much, telecommuting more recently since this thing started, with a lot of safety precautions obviously in place. So I think, you know, right now, I think ICS, the Incident Command System, is great. It's a great template for us to use, and we have a safety officer in there. It's really meant for the field. So in our Emergency Operations Center in San Francisco, we have a wellness officer and a team. We have a wellness room. We talk about wellness at almost all of our meetings. And because we've become this close-knit family of 1,000 people, we do ask how people are doing, and maybe not in the meeting, but, you know, because we are there physically walking around, and I know that this is hard for folks because most folks are working on Zoom and they're tired and there's that Zoom fatigue. But, you know, I get to walk around the 3 stories of Moscone, our convention center, and like I said earlier, look in people's eyes and say, oh, Sonny, you look a little tired. How are you doing? And not just kind of BS it and say, you're doing great, keep going, soldier, we got this, but really stopping and taking the time and taking a breath and letting the person answer. I think as leaders, we want everyone to be okay. We don't have time to deal with stress. We have so much pressure on us from the higher levels. This is a serious pandemic. People have obviously died. People are sick. Resources are scarce. But if we don't take the time and put that time, I put time into my calendar to walk around. Don't tell my colleagues that, but I calendar it out so that I know I need to get off my chair and walk around and look in people's eyes. So that's one of them. I think it's just, again, talking about it more as much as we can. You know, honestly, we do have a wellness room, but a lot of my emergency management colleagues say, I don't have time to go take a break and talk to someone. Sometimes we have therapists that come in, they say, we have too much work to do. So culturally, it's been tough. The Department of Public Health, though, and our public health colleagues have been great about really reminding all of us emergency managers and others to stop and take a break. So it's cultural. We have the power to shift it, as I've said. It's just we have to do it and take the time. In leadership, we talk about transformational leaders. They're not all at the top of the org chart. They're throughout the organization. So find those folks that really have emotional intelligence, are empathetic, and send them out. Sometimes I send my team out and say, hey, can you go check on that person on the second floor, just see how they're doing and come back and tell me how it's going. People don't have to disclose all their personal info, but just, you know, just get to know people in person. That helps.
Thanks, Jill. And I think you lead right into the question I want to lead into Chris. Chris, you're still with us. You know, we have a lot of leaders in emergency management on this attendee here in this webinar. Is there maybe just 30 seconds of things that they need to consider from the clinical side where they can maybe increase their, you know, as Jill mentioned, maybe their emotional intelligence, maybe other things that they can, you know, prep themselves for? And of course, this is a larger conversation for another webinar, but maybe a little bit just to distill it for us. And then Vince, I'm going to come with you with one last question.
Okay, it's beat the clock here. So there was one thing that maybe this will help answer your question because it'll be a resource that people can then look at and unpack, and, you know, that would take longer than I have time available now. But we are simultaneously, while this conversation is going on, the American Psychiatric Association is holding their annual meeting virtually. And there's a psychiatrist, Ben Rosen, who's at University of Toronto, and he presented a very important presentation that's available publicly. You don't have to be a member or anything like that, on a peer support coaching model that he referred to as psychological PPE, which I like that term. And he talks about literally unpacking how they do coaching sessions, what's the difference between a peer coach and someone providing therapy. There's still challenges with it. You know, how do we fit it in? Like Jill was talking about, you know, I don't have time for this. How do you deal with those challenges of making it fit into an already overfilled schedule? If people don't necessarily feel comfortable in group settings, how you manage that, and then the boundary issues. And they are also going to develop an online course and handbook for this that will be available to others as well. So people can ping me or just Google it if they can't find it. But I think that will go a long way for leadership to see a good model that has an empirical evaluation of it, and, you know, is unvarnished, because they also talked about some of the challenges. It's not a perfect model, but it's, I think, a really great direction to move in with psychological PPE.
Thanks, Chris. And just to beat the clock a little bit, Vince, if you could just quickly get 30 seconds, maybe one sentence or two that really sums up, Vince, sums up the larger goals in emergency management community to prove our wellness. You have your foot in a lot of places. Maybe you can help sum it up and then kick it to Kim from it.
Certainly. Thank you, Sonny. I think that we have to take care of each other. We all love this profession. We wouldn't otherwise be in it. We're in it for all of the right reasons. We need to make sure that we pull together as a profession, and to help ourselves and protect ourselves and protect the integrity of the work that we do for the people that so much trust us to take care of them. So we have to keep going, and we have to keep supporting each other. And that's I think the gist of everything that we've discussed here.
Thank you so much, Vince. Thank you to all our panelists today and speakers for all the great insights. Thanks everyone for participating in the chat. It really, from hearing from everyone, just seems like we have, you know, a positive or kind of grim outlook, kind of that double tap with how we can improve mental wellness and mental health in this field. We're really looking forward to continuing the conversation. Ending on a positive. We've got the conversation started, and that is huge. Let's keep it going. And with that, we're actually going to put some of those resources back up on the screen for you in case you do know anybody in crisis, and you can take a look at that. Thank you again. I want to thank the Journal of Emergency Management, Richard DeVito, for all of his work in making this happen and bringing us all together today. And with that, thank you to everyone again. Please stay tuned for our next webinar, as well as the Journal of Emergency Management Special Edition, which is online right now, and additional articles are also being posted. And with that, I wish everyone well. Have a wonderful day, and thank you for joining us today.
On behalf of the Journal of Emergency Management, I want to thank all of our panelists for an outstanding discussion today. Please take a look at these resources that are available immediately if you have people that are in need. And I welcome you to stay tuned for the upcoming surveys and upcoming webinars that we'll be bringing forth. So once again, I want to thank you for joining us today. Be well, and thank you for all you do for us across the globe. Good day.